And I want to definitely thank Pankey Institute for allowing me to share some things with you relative to one of my favorite topics, which is the baby boomer. I pretty well know this topic since not too long ago. In the mail, I received my AARP magazine. Those of you who are baby boomers, I know the first time that you received anything in the mail from AARP, you were the first to hide it, throw it in the trash. And then after a while of getting that, I began to realize there was a fair number of things that were in that AARP newsletter that I actually wanted to read that was relevant to me. So for us today, you and I want to take a look at what I think I've distilled down, which to me is like 4 areas that if I was managing a dental practice and I was managing a practice that had any baby boomers in it, these were the 4 conditions that I would be taking a look at. Now, if you look at the bottom of the screen and you see this album cover, first of all, if you don't know this album cover, we know for sure you're not a baby boomer. But if you do know the album cover, you know, well, I'm partial. This is the best rock and roll band of all time because I am a baby boomer. And you do know that this is Abbey Road. You do know that the guy in the white is not Jesus. And you do realize that playing the album backwards is not satanic. So anything that I have said so far kind of tells you actually what generation you're in. Now, as any speaker, when we start, we should always tell you our disclosures, our conflicts of interest. And so throughout this program, I will be as non-commercial as possible. But every now and then you may ask me, you know, what, for the most part, what do you use with your patients? And so for these things, Florida Pro, Periosciences, BioLace, Philips, Probiora, Hufridi, all of these things will be discussed along with other products that are in the same categories. So I will do my best not to show any type of influence as we have this conversation. It's just the educator in me. So one should never start a program without you and I both know. It's kind of like a Covey thing. Think first with the end in mind. What will you take home today with this? What do I want you to consider? But moreover, what do I want you as the receiver to get? So 1, establish techniques on how to communicate with baby boomers. While you may be one and you may think you're an expert on one, there are some tactics and some scripting. Number 2, let's dive into those 4 things. We're going to look at periodontics, especially non-surgical. You and I are going to look at xerostomia. Relative to xerostomia will be this thing called caries, especially root caries. And then we're going to end our program with something that we know as our dental implants. So with that in mind, I don't know if you saw this on CNN, but if you're a baby boomer, I know what you thought. You said, you've got to be kidding me. How could a millennial sue their parents for their parents kicking them out? Well, you can appreciate, if you've still got some millennials living at home, that about 25% of all millennials are still living at home. And for that most part, it's a very interesting generation. However, through most of this, you and I will talk about all generations. But we really want to focus on that 77.3 million of what we call baby boomers. So when you look at this, and this is from the Pew report, everyone wants to sort of classify these categories of generations. But to me, this is fairly accurate. Born between 1928 and 45, and I can tell you right now, as I continue to go through this, you're going to be thinking about when you were born and where you fit into this. I know. So What we call the silent generation, that generation was born between 28 and 45. If you're born between 46 and 64, like myself, you're known as the baby boomer, and there's a reason for calling us baby boomers. When our parents got home from World War II, one of the first things they did was have kids. Then there's that Generation X. We call that the sort of the sandwich generation. Sometimes folks with levity call them sort of the schizophrenic generation. They're caught between the millennials and the baby boomers, so they really don't know who they are. And I would suggest that's probably a few of you on this call. Our millennials, especially if you're a young practitioner, you're born between 81 and 96. And now we have a new group added to our categories, in which we call them disease, the centennials, and they are born between 97 and 2012. And yes, there will be another generation born between 2012 and probably 2022. So as we look at this, you and I are going to talk about not every one of these generations, but we're going to sort of define who they are. So now we talked about those Xers. Now, what I want to do for just a moment is suggest to you that what forms us sort of as a generation is basically what we went through. So if you look at Generation Xers, again, that group born after 65, look at what sort of created them. Diversity, thinking globally, balance, techno-literacy, fun, informality, self-reliance, pragmatism. But what created that? Watergate, Apple, 3 Mile Island, the hostage crisis, Lenin being assassinated. For me, as a baby boomer, you can imagine, I had the trifecta. I had JFK, I had Bobby Kennedy, and I had Martin Luther King. Reagan elected. You remember probably where you were, what the weather was like in the Challenger disaster. I'm right now in Florida, 60 miles from NASA. And I generally, if I'm in town, watch every launch. But I can remember watching that and the outcome of that. Stock market plummet, Exxon, the fall of the Berlin Wall, all of these formulated if you are a Gen Xer. Now I want to contrast that with millennials. Millennials born after 96, optimism, civic duty, confidence, achievement, sociability, morality, smarts, diversity. Millennials. But look what created their kind of value systems. The Oklahoma bombing, Columbine, the technology literal explosion, and then the Clinton-Lewinsky scandal, in which we begin to sort of rethink politics and ethics, etc. But I want to go back to our baby boomer. They're born, if you're thinking about a boomer turning 50, they turn every 8.5 seconds is a boomer. And for the next 18 years, the baby boomer will turn 65 at a rate of 8,000 a day. Well, what does that have to do with us and dentistry? Well, let me tell you about them. First of all, our average income is $71,000 per person. Our average personal net worth is $236,000. We can expect to live to be 85 or even longer. But you know what's interesting? We're still in the workforce. That also includes dentists. I remember when I was getting out of dental school, if somebody said that a dentist was 60, 65, my goodness, I wondered, can they even hold a handpiece? Wow, look at it now. We have actively outstanding practitioners that are practicing now and being in their 70s and even 80s. And when you think about who buys stuff, I can suggest to you, because I have some relationship with a laser company, you would be shocked. It's baby boomers that are buying the technology. First of all, they have the wherewithal to do it. And secondly, they actually understand where it would fit into their practice. So let's look at them as patients then. They're the only group that actually spent more money for dentistry than any other between 2010 and 2019. They have the highest level of expenditures. Now, part of that is because they've got more going wrong. And actually, only 41% have dental coverage. You'll notice that if you're in a fee-for-service practice, that generation there is going to be the baby boomer. We always say that when you think about how people pay, our silent generation, they pay for it in cash. Our baby boomers pay for it in debit card. Our Xers pay for it in credit card, and they are the generation that has the highest credit card debt. Millennials, sorry, they pay for their dentistry with their parents' credit card. And so therefore, when we look at baby boomers, let's look at their values in seminal events. Optimism, personal gratification, health and wellness is very important to us. Personal growth, youth, work involvement. By the way, we are heavily involved in Facebook, probably about as much as anyone. But what created us? McCarthy, Civil Rights Act. I mentioned about Kennedy, elected, assassinated. The Cuban Missile Crisis. I remember in middle school, in the Cuban Missile Crisis in Texas, you remember the drill where we all went under the desks? Every day we had this drill. Now, as if a Russian missile coming from Cuba, that desk was going to be able to keep us out of harm's way. I doubt it. The first lunar landing. And as I always say, if there was doom and gloom during my time, we all went to Woodstock, smoked up, and didn't care anymore. But these things created our value systems. And you probably know this if you're a baby boomer Xer and you're hiring millennials. They're very different, aren't they? Whether they be associates, or they be part of your dental hygiene team, or your patient greeters, managers. But look at millennials. They're collaborative, but they do need some supervision and structure. They're optimistic. However, they're somewhat inexperienced with handling people issues. And I think probably technology has to do with that. Tenacity, but they do not like to do perfunctory work. They like tasks, but they don't like to repeat the same thing over and over. Multitasking, yes, but they get impatient. And they're definitely technological savvy with confidence. But now let's contrast that with the baby boomer. Service-oriented. By the way, we're not necessarily the most budget-minded folks. We're driven. We don't care for conflict. And we'll talk about that when we talk about at the chair. We're good at relationships. And I always say, if you want to have outstanding folks on your team, especially on the phone, our patient greeters, managers, you want to hire baby boomers. We are good team players, but you're going to see in a moment, yes, we are self-centered. And we actually are a generation that wants to please. So we're very overly sensitive to feedback, especially when you tell us our oral hygiene is poor. And so what do the generations say about us? Well, our peers that are older than they say they're self-absorbed. Our Gen Xers out there say that we're workaholics and that we're too political. Our millennials say we work too much. Now, I want to give you some myths about baby boomers. We're not on our way out. At least I'm not. And you on this webinar, I know you're not out too. You're learning a great deal, especially during this time. They'll grow up. No, we won't. We were a part of the generation of rock and roll. We shower in the morning to Led Zeppelin. We've not had it easy. Our parents grew up in the Depression. I can tell you, my mom said, eat everything on your plate. Every morning I got up, save, save, save. And maybe that's why some of us have a more comfortable retirement. And as I mentioned before, we're never going to quit learning. We love learning. You go to CE courses, you see baby boomers. But I will admit, we are workaholics. So what motivates boomers? And by the way, all the slides that you see at the end of this, I am going to give you an email that if you email me, I'm going to send you this entire presentation in color. The email will go nowhere else but to me, but I believe in sharing. That's what we're here about. And nothing, no entity is better at that than Pankey Institute. We're here to share. We're here that our patients get the best care that they could ever receive. So what motivates boomers? You're important to our success. You're valued here. Your contribution is unique. We need you. I approve of you. You're worthy. So throughout the entire time that you're doing your case presentations, interrelating with them, these are the things you need to be thinking. And by the way, they are a phenomenal population for you for dentistry. I'm going to be a little bit discriminating on profiling. My friends, if I was starting a practice tomorrow, I would start it in an affluent, baby booming community. There's no better place than the villages here in the state of Florida. We probably have the largest affluent baby booming community in the world. And no matter where I am, I was in Dubai speaking. There was an infomercial on the villages, and I'm not even thinking we should call them retirement centers anymore. But that's where I would be. Because boomers have 80% of the US net worth. So now let's you and I go into these 4 conditions. 1, baby boomers' iconic disease is chronic inflammatory diseases. I think you probably know that. You go on television and you see ads, pharmaceutical ads. Who are they aimed at? Me. What are the diseases of the baby boomer? Cardiovascular disease, diabetes, Alzheimer's, arthritis, rheumatoid arthritis. Did you know all of those were chronic inflammatory diseases? Did you know that all of those chronic inflammatory diseases have incredible, uncanny parallels? Yes, with periodontal diseases. And it's not that I'm a periodontist and it's one of my favorite diseases, but if you've looked at this oral systemic link, it's really not oral systemic link. It's really periosystemic link. And we're going to show you why. If you look at the activity of inflammatory systems in the center of major human diseases, everything demonstrates that it's Alzheimer's, rheumatoid, asthma, that obesity, osteoporosis, gastric cancer, osteoarthritis. All of these are age-related, and all of them have very common systems relative to what we call host modulation. I think you know that just because you got plaque does not mean you've got perio disease. You got these folks that are in their 90s that have horrendous oral hygiene. You can't wait to get out the ultrasonic and blast them. You can't wait to get into the oral hygiene business with them about brushing and flossing. You look at the radiograph, guess what? The bone is within 2 millimeters of the CEJ. The bone is looking up at the calculus and saying at the pipe breaking down. And then me as a periodontist, I've got patients that are 40, 45, that are religious with their oral hygiene, see me every 3 months, and have 80, 90% bone loss. Friends, it's not that simple. What it is is a host reaction to a stimulus. Whether that be biofilm, we call it microbiome now, whether that be a collusion, it really doesn't matter to me. But when you look at that inflammation around that canine, if I were to do a biopsy, if you look inside there, I mean, there is a lot of stuff happening. And I don't mean the bacteria over here. I mean this entire stimulation with neutrophils, hyperactive neutrophils, lymphocytes, all of these kinds of inflammatory cytokines, lymphokines, all of that. And all of that is related to a certain degree relative to chronic inflammatory sequencing. So if it were me, the way I would be managing these folks, and I have another webinar scheduled with you in a couple of weeks, in which we'll really get down to managing at every single level. But if it were me, I'd be looking at lipid mediators. I would be looking at omega-3s. I would be looking at aspirin. I would be looking at managing this not only as an infection, but as a chronic inflammatory disease. And no one knows themselves better than baby boomers. If they have got rheumatoid arthritis, my friends, they know everything there is to know about rheumatoid arthritis. Because they're also what? The holistic generation. They're the generation that wants to manage themselves as much as possible. So let me talk to you about our first grouping, perio. If you and I look at the most recent CDC program on how much periodontal disease is out there, it demonstrates that 47.2% of all Americans have periodontitis. I didn't say gingivitis, I said periodontitis. In categories of 9% mild early, 30% moderate, and 9% severe. When I speak with you again, we'll actually look at those categories. We will look at reimbursement. We will look at third party. But now if I go one step further, that's for those that are 30 years or older. Did you know that patients that are 65 or older, that number jumps up to 2 out of 3 Americans that are 65 or older have periodontitis. Have periodontitis and should not be receiving, for the most part, a prophylaxis. That will come later. So I'm asking you not to just look at calculus, but start to look at inflammation in the gingiva. So therefore, you and I do need to speak to this whole thing relative to the periosystemic link. Now, this does not mean that if a baby boomer stops flossing, they're going to die. No. What it does mean is that baby boomers, for the most part, have most of these systemic diseases. So don't scare them. But if they do have a stent, perio becomes very important. And we know that by the Journal of Cardiology, not just the Journal of Periodontology. So, one thing that Dr. Pankey always told me, said, Sam, know your patient. Know your patient. Know your patient. Talk with them. Build relationships with them. I don't mean know just their pocket devs. Who was your previous dentist? Talk with them. Did you ever have any symptoms, signs of gum disease? Has any dentist ever mentioned gum disease? When was your last cleaning? Brothers, sisters, familial history of gum disease, use tobacco. And about questions about occlusion. And by the way, smart dental practices that I consult with, and I do that on occasion, I go into general practices and we have conversations about how to get your perio program up to where it needs to be. But we put this either on a tablet, we put this on a clipboard. These are the scripting that you want with your patients. But at the chair, you need to be looking at radiographs. You need to know where's the relationship of the bone to the CEJ. You need to be using periodontal probes. And not necessarily to determine whether something's 3.5 or 4, but to be able to look at the progression of periodontal disease, because, my friend, there are only two real serious ways we look at gum disease. And that is periodontal charting and radiographs. That's what we use. So therefore, you've got to find the furcas. What generation do you think is going to have more furcas than any other generation? By far, it's going to be the baby boomer, because they have the most attachment loss. And I don't care whether you want to get down to the nitty gritty of a class 2 plus or a 3, but I do believe that you need to have a furcation periodontal probe on the bracket table. Why? Because prognosis. If you ask me, you say, Sam, okay, it's your mouth. What would be the thing you would worry about the most if a periodontist looked in your mouth as far as your future? Do you know what it would be? It would not necessarily be pocket depths and periodontal probing. It would be mobility patterns and furcas. That will bite you more than anything else. So I hope you're using this code if you're in the United States. I hope you're using D0180, and forget about third party for a moment. But when you do a comprehensive periodontal exam, new patient especially, you want to document that in your software. Whether you get paid for it or not is another story and for another conversation. But D0180 tells the world that you did a complete periodontal charting. It can be on new or established patients, can be preceded by D0150, which is your overall comprehensive care code, and it should contain these things, from probing to medical history to overall exam. So yes, I had this bright idea with a few other folks to help hygienists do periodontal exams. We started out with Flauta probe. We ended up with something called VoiceWorks. And this is a way of being able to get folks to chart. And what that means is you don't need someone else in the room, that you are able to do a complete periodontal exam, which is speaking into the microphone. You don't have a hygienist leaving the mouth to go over and hit the keyboard. And what you get is a great chart. And all the hygienist has to do is just say, put a crown on number 2. No, sorry, put a crown on number 15, put an implant on number 2, and it does it for you. Previsor, I don't know if you're aware of this. This has been around for a good 10, 15 years. It's updated. This is one of the best risk assessment software programs that are out there. By the way, it's pretty well courtesy free, and it is incredibly reliable, very predictable, and it tells you if your patient is susceptible to perio caries and also oral oncology. Give it a try. So this is about actually what we call host modulation. If you're in sales, you know something called the elevator speech. The elevator speech is when a salesperson gets up on the elevator with you, and let's say you're at my dental school, which is University of Florida College of Dentistry. It has 11 floors. By the time I get up to the 11th floor, that salesperson has told me who they, I didn't know them from Adam. They've told me who they are, what they sell, and they've actually even got my contact information, and they've already possibly even made my appointment with them by saying something like, well, doctor, what are you doing next Wednesday at 5? So let's do an elevator speech for periodontitis. Elevator speeches are quick, to the point, they don't mess around. Periodontitis is nothing more than the body's reaction to a stimulus, including, by the way, occlusion, resulting in an overactive response that produces an inflammatory mediator that destroys your own self. You know that is autoimmune diseases. I'll be so bold to tell you today that we're starting to believe that periodontitis is not an infection, that it actually is a chronic inflammatory disease stimulated by such things as biofilm. If that's the case, then when we think about this, inflammation is really driven by what? Oxidative stress. And I'm not trying to get strange on you about free radicals, but if you do read the literature, you'll appreciate that chronic inflammatory diseases are generally drilled by oxidative stress. Free radicals looking for electrons, if they don't find them, they rob them from healthy cells. And that's the whole thing about inflammation. So wouldn't it be smart to start thinking about anti-inflammatories, to start thinking about those things that absorb free radicals? So when we look at a new patient, the baby boomer, this is the sequence that you need to be considering. As a new patient, by the way, there are systems, which we'll talk about later, of how to actually look at that new patient, do a quality comprehensive exam. We're now leaning more towards these 2-hour new patient examinations with the hygienist to a certain degree. I'm being apolitical, but being like a nurse practitioner who gathers the data for us in the perio realm. You're still collecting your data in the overall restorative realm. And then we go through a cascade of events, depending upon how that patient presented. And so therefore, I highly suggest that you invest in decision trees, that your whole team knows what's happening with your patients. It's almost like building a Camry if you're Toyota. There are systems, not that you don't personalize this, not that you don't build relationships, but at least you have a system, a process for doing this. Such things as don't ever ignore the D4355 code. Not that you're going to get paid for it by some third party, but no, it's the right thing to do if they've got so much biofilm and calculus that you can't even do a quality periodontal examination. So you're going to do a D4355, a gross debridement, and you're going to wait 2 to 3 weeks before you go in and do your continuation of your examination, especially periodontal. And your oral hygiene for a baby boomer is going to be around a dentition that is a baby boomer dentition. Yes, they're going to have larger embrasure spaces. Yes, they're going to have more recession. Yes, they're going to have missing teeth. Yes, they're going to have implants that we're going to talk about here in a moment. But don't throw everything but the kitchen sink at them. And by the way, this again is something for another time, but quit throwing floss at periodontal patients. It doesn't work. It does not work. And we have the science to show it. Start using technology. Don't throw manual toothbrushes at baby boomers. I don't care which one you use, as long as it's got quality science. But start using electric toothbrushes. Start using those that have some science behind them, that have, whether they have more technology than you would like, at least use those that do what? At least have a timer that every 30 seconds is telling you to go to another quadrant. Baby boomers like that. They're into technology, plus you're going to get a better result. And start looking at things like oral irrigation. This is one of my favorites because I like the technology. This actually creates a microburst by mixing air and water. This could never have happened without Tesla. Thank you, lithium batteries. And that's how this thing is able to literally disrupt the biofilm. I didn't say remove it. Disrupt the biofilm in 30 seconds. So this is a wonderful gadget. I actually put medicaments in it, full strength medicaments, like essential oils. Have your baby boomer, especially because there may be some xerostomia involved, have your baby boomer doing all of their oral hygiene, please, at night before they go to bed. Don't have them doing their regimens in the morning. Everything shows they should be doing it at night. And be creative. Be creative. Use interproximal gadgets, whether they have implants or natural dentition. Try to use the biggest thing you can in between those interproximal spaces, and quit relying always on manual toothbrushes and dental floss for baby boomers. The jury is not out. They have a verdict. You want big things disrupting biofilm. And so therefore, when you look at these devices, let's talk about what you want to do at the chair. At the chair, you want to be the most effective you can in disrupting the biofilm. And in disrupting the biofilm, you want to use technology. You want to be thinking about ultrasonics in addition to curettes and scalers. You want to be thinking about those things that have the most impact on because when you disrupt a biofilm, the body does not see it as a stimulus. I don't know if you were aware of that. The body doesn't just see one organism and go crazy. The body sees a microbiome. And that's what we call microbiome dysbiosis. So therefore, look to technology. Start looking at ultrasonics. Start looking at air medicinal delivery systems. They're not your parents' sodium bicarbonate devices. I didn't want to use the brand name. These things are very different. These are erythritol and glycine. The technology is totally different in these kinds of devices. So when we look at this, you want to be looking at gingivitis as one swim lane and having a dental hygienist manage that 9%. You as a general practitioner now want to start be thinking about this middle swim lane of the early to moderate periodontitis. And I don't mean just doing SRP every 3 months. I mean actually doing minimally invasive periodontal surgical procedures. And yes, there's a third swim lane. In that moderate to severe, if you don't feel comfortable doing those kinds of procedures, that's where the periodontist comes in that 8 to 10%. So everyone has their role in this. But the bottom line is we can't continue to do prophies on periodontitis patients, and please, we can't continue to do just SRP, scaling and root planing, on patients that have moderate to severe periodontal disease. So let's go to our next one. How about spit? How about xerostomia? Wow, you're seeing it, I hope. The baby boomer generation is the generation of xerostomia. And there are reasons for that. And it's not about just these salivary glands. You see this, the tongue sticks to the roof of the mouth. They can't speak. By the way, there's a real good reason for saliva. Not only about lubrication, but it is a major source of oral antioxidants. And the symptoms there are oral dryness, halitosis, difficulty in swallowing, decreased retention of the denture. Having them drink more water does not help because that just removes the natural antioxidants. Their mucosa is dry, glossary. They have angular chelosis. And by the way, they have caries, especially subgingival caries, root caries, caries under all those restorations that you did. Those restorations that lasted for 20, 25 years, and all of a sudden the hygienist says, Dr. Lau, I'm not sure what's going on, but my ultrasonic tip went into something and came back out. What do you think that is? It's not good. So you're going to see more and more and more root caries. I love this by Roberts. Not just children, 93% of boomers have caries, not just occlusal, 50% have root decay. Flossing is not effective. Disinfect the mouth, not just the dentures. Unaware of xerostomia, you gotta ask them. The diet is still critical. Fluoride is not enough. You need to be thinking about xylitol. varnishes, and risk assessment is absolutely critical. You and I are going to see more and more and more of this. So therefore, this is just using a dental laser. I enjoy this particular all tissue laser because it can not only do the caries, but it can also do the gingivectomy, all using the same tip. You see here, we're doing the gingivectomy. This particular laser can remove the composite because erbium lasers look for water in composites. So you see that we're not only refining the prep, we're removing the composite. You see how clean the gingivectomy is done. All this is being done in one setting, and you see the final with no hemorrhage and the area restored. So when we look at these, we appreciate, by the way, that it is not only baby boomers. 30% of millennials visit their dentist annually. Isn't that shocking? 30% of millennials have tooth decay. 35% of millennials have trouble chewing. 38% have oral problems that make life less satisfying. So it's not just about our baby boomers. But for baby boomers with this thing called xerostomia, it's about foods, especially drugs, systemic factors, dehydration. So radiation patients, 40,000 people each year with head and neck cancer. Sjogren's. Did you know there are 4 million Americans with Sjogren's? If you've ever known anyone with Sjogren's, you know how devastating that is, especially for the post-menopausal female, to have no tears, no vaginal secretions, no saliva. So when we think about prevention, first of all, recognize it. Intercept with xylitol and fluoride. Start thinking about salivary stimulants. Consider salivary substitutes, especially those that have glycerin in them. These are several companies that all of a sudden, you've seen the last 2 years, they're everywhere with salivary substitutes, Zerolubes, some of the tried and true ones that have been around for years, some of the new ones that are on. But the point being is recognize it, understand it, start looking for caries. Unfortunately, because this is a disease of the minor salivary glands, when we talk about the ones that are related to the pharmacokinetics, the pharmaceuticals out there, which by the way is most of our folks that are baby boomers, including antidepressant, anti-anxiety, and others, that these are just palliative. There are some products out there that are antioxidants. This just happens to be one of them. This is AO Prevantage Gel that has a naturally occurring antioxidant in it, with in addition to the things that are essential oils and xylitol. This is a company that makes certain products that have these antioxidants in them. And when there are studies done with Baylor, there are 40 patients using this gel, this AO gel. 80% reported extremely positive results in 48 hours. And Dennis Abbott, near Dallas, he manages dental oncology patients. He is a dentist. He, using this gel, found 92% improvement, even in our radiation-induced xerostomia patients. So it's something that you may want to take a look at. And when we use this AO Prevantage Gel, the more acute the condition, the more frequent we use it. We have some severe xerostomia patients that actually start out with placing 1 drop on the tongue 5 times a day, and then decreasing over time. Now, if your xerostomia is due to pharmaceuticals, and you stop taking the pharmaceuticals, well, then you can stop taking the gel. I do want to suggest to you at some point that we need to start thinking about being in the business of actually providing these products for our patients. I want us to start thinking about our hygienists, that the fact that we should be doing 40% of the services beyond the prophylaxis, 50% of the dentist production coming from hygiene operatories. And please, no hygiene, in the hygiene operatory, no treatment plans. So we need to be thinking seriously of hygiene productivity beyond just them cleaning teeth. So when we talk about oral hygiene instruction for them, we're talking about these kinds of devices that we've spoken to you before, including probiotics, including such things that are going to change the flora into other areas. So let's conclude with our fourth. One was perio, 2 was xerostomy, 3 was caries, and let's end with our fourth. My friends, there are a lot of implants being placed in baby boomers. It's a huge financial deal. And we're going to talk about the failure rate. There's a huge difference between a tooth and an implant, primarily the fact there's no PDLs and there's no cementum on those implants. I hope you can appreciate that we must manage all implant disease. There is no watching and waiting and monitoring on implant mucositis. And definitely you must intercept with implantitis, which we're going to speak about. You know, implantitis is sort of being the gingivitis of implants. It has the presence of inflammation. Here's where you see hemorrhage by general probing, and you see a level of suppuration, pus. For the most part, it is reversible, but it takes a heck of a lot longer to reverse it than it does with gingivitis of our natural teeth. Really interesting. So the pathology may be different, although the bugs are the same. So when we're managing mucositis, we do know left unattended, it possibly can end up as implantitis. So we need to intercept that, and we need to intercept it now. So I may be speaking to dental hygienists, since 98% of all implant disease is pretty well discovered and managed by our dental hygienists. So I do need you to use probes. I don't care whether it's a metal probe or plastic probe. I like plastic probes because they bend to get around some of these implants. You want to be looking for bleeding and suppuration. You want to be taking radiographs and looking at the relationship of the bone to the abutment and especially to the threads. And you want to have a system by which you, from a perfunctory standpoint, take those radiographs on a particular system, whether it be every year, every 2 years, it's up to you. We take radiographs every 6 months after placed for the first year, and then we go to every year thereafter. And you want to evaluate the occlusion and attached gingiva. This is for a whole nother webinar, but please look at occlusion and please look at the amount of keratinized attached gingiva. We're getting away from probing implants, looking at numbers. We're actually probing more to find suppuration and bleeding. It's not easy probing these things. We're looking more and more at bone. We're looking at attached gingiva. We're looking at ways to actually be innovative, to actually remove the biofilm, using interdental brushes, especially around these all-on-4 and all-on-6s that you cannot take off. As you know, this is very, very difficult. Again, we're using a lot of electric toothbrushes around our implants. We are not, for the most part, using manual instrumentation. You want to do it? Be my guest. I'm sure you're asking yourself why. You don't want to use anything metallic around implants, including ultrasonics, unless they have some type of ceramic or polymer on the end of those ultrasonics. There's now clinical evidence to go back now to these things called air delivery systems. And that's what most of us who are smart are doing around implants. Our hygienists have these systems to remove the biofilms. And here is our patient, and that's 30 seconds later using an air medicinal delivery system at the chair. Strongly advise you to investigate these things. But for implantitis, it's a whole nother ballgame. This is where we've got bone loss. And I want to reinforce with you, when you see bone loss, you need to intercept. Either you do it or you need to refer it to someone. But I'm not talking about normal cupping from placing an implant too far apical. I'm talking about true implantitis. I'm talking about this kind of implantitis that unfortunately got too far out. It should have been intercepted the first time you saw any evidence of any deosseointegration around the flap. And so you're looking at the mesial. I would even say, even at the distal, this has gone too far along to just sit there. And who knows better how to find this? It's going to be our hygienist. And even if only 10% of our implants were lost, by the way, we think it's 15 to 20% now, even if 10% were lost a year, that would be 270,000 implants. And over 5 years, that would be 1.4 million implants. And when you take an implant out and replace it, it's very expensive, not including what the patients think. So, implantitis, history of chronic periodontitis, poor oral hygiene, not showing up for implant therapy, smoking, lack of implant keratinized mucosa, positioning of the implants, and occlusion. So therefore, we can't have this happen. If this is a patient of record, this should not happen. And where are we going with this? We're going again with air polishing stuff. We're going with biologics. We're going with osseous grafting. But you've got to decontaminate these implant surfaces to make that happen. And this is where laser is coming in. Using all tissue lasers to decontaminate these surfaces and getting what you see on the left to what you see on the right. Lasers going in and actually sort of making these implant surfaces the same as they were when they came out of the package. So please, early detection is critical. You've got to create restorative so that the patient and the hygienist can access it. There's a difference between a tooth and an implant surface. Consider now using lasers. I'm talking about erbium lasers or even CO2 lasers to decontaminate those surfaces. Because when you start to look at lasers now, lasers are moving very, very much in dentistry the same. I don't think you would have ophthalmology surgery done with a 15C blade. So whether it be diodes for this, whether it be moving forward, lasers do everything. Your baby boomer patient that comes in with an aphthous ulcer, here we go. Your baby boomer patient that comes in and does not want pigment around their gingiva for aesthetics, here we go. The patient that has this area, venous lake, which many baby boomers have, here we go. And that is 2 weeks later. The baby boomer that doesn't like their smile, here we go, with being able to do aesthetic crown lengthening with a laser, with no sutures and no blades. So let me conclude. If you're going to market to boomers, they want information based on outcomes. You've got to talk to them. They are frequent users of social network and blogs, and everything you tell them, they're going to go that night and look up on Google. I promise you. Face to face, eye to eye is the most important. Now, they may go on your web site, but they are only going to choose you after their peer tells them it's okay. So please understand, boomers don't go on websites and choose a dentist. Boomers go on websites to get background on you, but they choose a dentist based on a relationship that you have with one of your other patients. So I guess what I'm going to say to you is this. I know, because I'm guilty too, that when a new patient comes into my practice, I am guilty of looking at when they were born, how old they are, and do they look younger or older than I do. If they look younger than I do, I kind of go into their medical history a little bit more and ask them, what are you taking? Are you taking antioxidants? What are you doing? What face cream are you using? When they look older than I do, I say, you know, I'm doing something right. But I'm going to suggest to you, your number one patient in your practice for your present and future success is a baby boomer. If they're born between 46 and 66, my friends, I need you to go out there, and if you got to give them mimosas, you got to get them drunk, I don't care. Throw rose petals in front of them. But they are phenomenal patients. They have the most conditions. They'll stay with you forever. They have allegiance to you. And they've got some money to pay for you. It's not just this presentation, but every presentation I always end with this. I was able to talk with Dr. Pankey, and I said, you know, Dr. Pankey, I'm really into mission statements. What's your mission statement? He said, Sam, the goal of my practice has always been to simply help my patients retain their teeth all of their lives if possible in maximum comfort, function, health, and aesthetics. And if you adhere to the Covey principles and what would you want on your tombstone when it comes to dentistry, I would say to help my patients keep their teeth all of their life if possible for these very things. This is my email. I'll be more than happy to send you this presentation. I look forward to some future webinars with you. Again, I'm so appreciative. I still believe that the Pankey Institute and my relationship with them, starting with Dr. Mahan in the late 1980s, is probably one of the most powerful continuing education entities that exist out there. And I really, really appreciate them for allowing them to help me with you. Thank you very much.
Sam, thank you so much. Incredible job. Can you hang out and answer a couple of quick questions that popped up for us?
Sure. Could you give me the questions, since if I mess with what you're seeing?
I will. I'll read them to you.
We will never do the questions.
Okay. All right. The first one says, good afternoon, Dr. Lau. How often do you recommend a comprehensive periodontal exam on patients who currently receive perio maintenance? Patients that have been in your practice for more than 2 years versus on new patients?
Great question. And now we're talking process. That's why I like that question. Your repeat of a comprehensive exam, in my mind, is based on risk. So here's the deal. If your patient is low risk, let's put in perspective. Your patient is over 45, has very little periodontitis, and still has local factors. In my mind, that comprehensive periodontal examination should be probably every 18 to 24 months. I'm talking about, when I say comprehensive periodontal examination, I mean writing all the numbers down, not just, there's no such thing as spot checking, by the way. What you always want to do is look at every site at risk every time they come in. But to do a complete comprehensive exam, in my mind, it's every 18 to 24 months. But if it's a patient that has a lot of restorative and is susceptible to periodontal disease, in other words, has had periodontal surgery, has moderate to severe periodontitis in the past, that patient gets a comprehensive periodontal examination every year. So in my mind, you base it on risk, just as you should do with caries.
Awesome. All right, so the next one says, Dr. Lau, it sounds like we shouldn't give our patients floss and brush in their goodie bags, but maybe a Sonicare brush head. So I guess just confirming you think that that's an effective tool.
Well, I get beat up about this because some of you popped out of the womb flossing teeth, especially you hygienists out there that are anal. But you can't have science when you like it and not have science when you don't like it. Periodontal patients should not be on floss. They should be on interdental brushes. They should be, sorry, I'll give a brand name, but I love them, soft picks. They should be dipping those brushes in medicaments. I don't really care what it is. Right now, essential oils are very powerful. So yes, if you could, goodie bags, in my mind, would be electric brushes. Don't care which one you have. I would also suggest, though, if you're going to use electric brush, please use one that's got some science, not some knockoff that's, you know, that's a blue light special with 2 D cells in it. But yes, it's time to change based on your patient.
Awesome. Next question is, what's your opinion or thought about aerosolation, as far as I'm sure they mean ultrasonics and Cavitron, after we get done with COVID-19 or when we're back in our offices?
Everyone is asking the same question, including, my friends, high-speed handpieces. It's all going to be in the same grouping. I'm hoping that we can have some common sense here and realize that if we pre-rinse, especially for that 30 to 60 seconds, which I've advocated from the beginning, and especially with those kinds of rinses that are antiviral, and I don't know if you're aware, but some of them are, including your hydrogen peroxide off your shelf at 1.5%. I mean, in other words, cutting it in half. So putting even hydrogen peroxide and your favorite mouthwash together. But please understand that this is nothing new. And we do know that the coronavirus is very susceptible to these pre-rinses. Now, having said that, it's going to be up to what? Regulatory, OSHA, American Dental Association, and others to make those suggestions. But personally, I've read this data for the last 5 years. I feel very confident, whether it happens or not, but that's what we should be doing. Now, with ultrasonics, every time I've ever done an advanced ultrasonic course, which we will sort of do one with for the Pankey Institute with Sherry Kay here in a little bit, I've always said you use way, way, way too much water in the first place. So it may be that we're going to have to do high-speed evacuation with anything that is aerosol, but I know we can overcome this.
Awesome. There were a number of questions about lasers. And so multiple people asked what type of laser, and I kind of guesstimated, I think it was an erbium YAG potentially, or ND YAG you were talking about. But specifically what kind of laser, any specific brands people should look at. And then there was a question about whether or not the laser would heat the pulp when you were showing that class 5 restoration.
Oh, excellent. All lasers used appropriately and FDA cleared or approved have all gone through those pulp thermal studies, every single one of them. And they absolutely have no effect whatsoever on the pulp. You've got to get above 5 degrees centigrade for these things, but if you use them on the settings, they are outstanding, including diodes. Now, having said that, you know, there are diodes out there like the Epic X from Biolase, Ultradent. Having said that, however, AMD, having said that, my preference, because of versatility, is going to be an all-tissue laser. Whether that be, as you mentioned, Lee, whether it be an erbium YAG, an erbium chromium YSGG, a waterlase from Biolase, possibly even a CO2. But I like them for the versatility. That class 5 that we did, that was done with an all-tissue erbium chromium YSGG laser. That was a Biolase waterlase laser. But there's several brands out there. But it's time to start thinking about laser. And I'll tell you one primary reason. We're moving towards minimally invasive dentistry. If you haven't caught on, believe me, nobody takes a gallbladder out cutting you from your eye tooth to your toenail. They suck it out through the belly button. Lasers are a whole new generation of what I consider to be not only a minimally invasive, microinvasive, but also holistic because it's light energy. It's nothing but light.
All right, so we had about 7 people who asked, what essential oils? What essential oils are you recommending either in the air or on their stimulator?
I'm doing my best to stay within the SERP. You're laughing, Lee.
I know, I'm going, okay, they're trying to pin you to the wall here,
No,
Sam.
This will be my last webinar I ever do. If we get our Pankey family gets audited by SERP or AGD paste. So I've already done my disclaimers. Menthol thymol, menthol thymol, menthol thymol. There's one that you don't like the taste that's been around for 50 years. It is fantastic. But all you have to do is go on the materials. Even Periosciences as a gel has menthol thymol in it, but the 2 primary ones are menthol thymol. By the way, we're seeing a decrease in the use of chlorhexidine in a dental practice. Now, it may resurge after this situation that we're in, because it is also antiviral, but also is menthol thymol. Menthol thymol is also essential oils that are also antiviral. But anything, there's many things out there, but one of them is Listerine.
All right, so last 2 questions. One is, could you repeat the 4 things again? Perio, xerostomia, mucositis. What was the 4th thing? Someone wrote as the question.
Sure. If I'm managing a baby boomer over at the Villages, which Lee knows well, in fact, Lee and I will probably be at the Villages. I'll be there sooner than her. She's probably got about another 40 years on me. Since she's a former Gator, she knows where that area is. But if I am managing baby boomers, the 4 things I'm looking at for them is bone loss periodontitis, number 1. Number 2, xerostomia, which we now know 27% of all baby boomers have xerostomia. 3 would be caries, especially root caries. And 4th would be the management of implant diseases, whether it be mucositis or implantitis. Those would be the 4 things that would be high on my list.
Awesome. And then last question, and then we'll let you go, because Sam is going to be back with us to do another webinar, so you guys can store up all your questions for next time. Was simply, if you're having the patient go back and forth between you and a periodontist, and they're doing the full mouth probing, should you do it also in your office if they're actually sending it and you're getting a copy of theirs?
Wow, great question. And it has to do with who is the provider of record. We live in Florida. Really high number of attorneys in Florida. Don't take any chances. If you have a periodontist you trust, and that periodontist, you're alternating the root care, and you feel very comfortable with them, I think their charting is probably second to none. But they should be sending it to you. Again, not to beat the drum, but if it's Florida Probe, they can electronically send it to you, as they do with third parties. But I would know where those areas of concern are. And if I was a dentist, I would be going after those areas of concern just to make sure, because having more than 2 eyes is better than no eyes. So it totally depends. If you have a quality, trusting relationship with a periodontist, believe me, their numbers are going to be right.
Awesome. All right, Sam, thank you so much again. Such a pleasure. I know everybody enjoyed it. We're really appreciative. And now we've just kind of got everybody super excited about when you're back with us again. Couldn't possibly express my thanks enough. So enjoy, everybody stay well. And our next webinar is Wednesday. Same time, register at the same place, pankeygram.org/webinars. And I will actually be leading the one on Wednesday, and we're going to talk about using a JAMS protocol to assess functional risk. All right, everybody, have a great evening.